Welcome back to PCA Deep Dive, where we cut through outdated narratives and surface what the evidence actually says. Our goal is simple: to take complex, peer-reviewed research and translate it into clear, usable insight for clinicians, policymakers, and decision-makers. Today's deep dive focuses on one of the most misunderstood areas in musculoskeletal care: spinal manipulation and chiropractic practice. Using a 2024 narrative review published in the Journal of Clinical Medicine, authored by researchers from Duke, Brown, and Case Western Reserve, we examine more than 50 years of clinical practice guidelines and over 6,000 peer-reviewed studies to answer a critical question. What does modern evidence actually say about the role, safety, and clinical value of spinal manipulative therapy in today's healthcare system? This is not historical opinion. This is current guideline-level evidence, and it has real implications for how musculoskeletal care should be delivered moving forward.
Okay, let's unpack this. For decades, the public conversation around spinal manipulation and, chiropractic care in general has been, well, it's been full of conflicting signals.
It really has. You hear historical claims, you hear a lot of skepticism, and frankly, a lot of it is just outdated information.
Exactly. So our mission today is to cut through all of that noise. We're going to do a deep dive into the absolute state-of-the-art evidence, what's available right now, not 5 years ago.
Right. And to do that, we're looking at a huge 2024 narrative review. It's published in the Journal of Clinical Medicine, and the authors, they're from major institutions: Duke, Brown, Case Western Reserve.
That affiliation alone tells you a lot. This discussion is firmly positioned within mainstream healthcare.
It is. And this review didn't just cherry-pick studies. It mapped over 50 years of research, focusing specifically on what modern medicine calls clinical practice guidelines, or CPGs, for spinal manipulative therapy. I'll probably just call it SMT.
And that's a crucial framework for you to keep in mind. The key initial takeaway from this huge review is crystal clear.
What is it?
It's that chiropractic is now formally and professionally established as a discipline that diagnoses and manages musculoskeletal disorders, MSK disorders.
Especially those affecting the spine.
Exactly. It's squarely placed within the modern spectrum of conservative MSK care.
And that defining statement really matters, doesn't it? Because it dictates the entire trajectory of the research we're about to talk about. If the scope is MSK management, the research has to prove it works and is safe in that context.
So if that's the position now, how quickly did the research, the academic side of things, respond? This is where the history gets really fascinating.
It does.
Our timeline for this starts pretty precisely in 1972. That's the year Medicare first authorized coverage for chiropractic SMT.
And that government acknowledgement, it seems like it just opened the floodgates.
It really did.
The review identified a remarkable number: 6,286 chiropractic-related publications between 1972 and 2024.
Wow. Over 6,000.
Yeah. And that number shows this steady, substantial upward trend, not just in the quantity of research, but, and this is critical, in the rigor of the research, too.
So think about that for a second. Over 6,000 peer-reviewed papers. That's not some fringe field. That's a major academic discipline hitting critical mass.
For sure. But the real story here, the story of its maturation, is how the focus of that research changed over time. The authors traced it using keyword analysis.
And they broke it down into phases, right?
Exactly. 3 distinct phases. Phase 1, which is basically everything before the year 2000, was foundational and, well, frankly, it was defensive.
What do you mean by defensive?
The keywords were all focused on things like history, legal aspects, and diagnosis. The research was reflecting those early struggles to just establish the profession's scope, get regulated, and argue for a place in the broader medical system.
So it sounds like they were spending their time just trying to prove they belonged at the table.
Precisely. Then, around the turn of the millennium, the focus pivots dramatically. And this was largely driven by some very visible, though often rare, case reports about adverse events.
Okay, so safety concerns.
Right. Suddenly, keywords like vertebral artery, stroke, and case report, they just surge in frequency. It shows the academic world responding directly, trying to address those safety concerns head on.
Which then leads us to the critical third phase. This is the modern era, right? Mid-2000s onward.
This is the scientific maturation phase.
Oh.
This is what led to the review we're talking about today. The keywords shift again, but this time to reflect really high-quality methods.
Like what?
You start seeing a huge increase in terms like randomized controlled trials, or RCTs, systematic review, and qualitative research.
And for you, the listener, this is the key insight. RCTs are the gold standard. They're what you use to prove an intervention causes an improvement, not just that it's associated with one.
Exactly. The focus is no longer on defending the practice. It's on synthesizing high-level evidence. And that directly refutes that old, outdated claim that the profession lacks a modern scientific foundation.
So if the research has matured to that point, producing all this high-level evidence, what do the official clinical practice guidelines, the literal instruction manuals for modern medicine, what do they actually say now?
That's the real measure of acceptance, isn't it? And the core strength of this review is that it maps exactly what those guidelines recommend.
How many did they look at?
They analyzed 33 CPGs published just between 2013 and 2024. And those generated 59 distinct recommendations related to SMT. We're not talking about single studies here. We're talking about official guideline-level endorsements.
Okay, let's start with the big one. The condition that gets the most attention and, honestly, the most money in healthcare.
Low back pain.
LBP.
Yep. What did the guidelines say?
LBP recommendations made up the majority of the statements they looked at, 21 in total. And the findings are, they're exceptionally strong.
How strong? Almost 90% of CPG statements favored SMT.
90%, wow.
But it's crucial to get the context right. SMT is favored as part of multimodal care.
So not in a vacuum.
Not at all. It means alongside things like exercise and usual medical care. It reinforces that whole integrated conservative model that the field is moving toward.
Okay, 90% is a huge number. But what about for persistent long-term issues? Does it still hold up for chronic low back pain?
The data for chronic LBP is even more impressive.
Really?
For chronic LBP specifically, 100% of the guideline recommendations they reviewed favored SMT.
100%. That seems, that's a revolutionary level of support in the guideline world, especially given the history.
It is. It means the evidence base for managing long-term persistent back pain is now considered exceptionally robust by these major medical organizations.
And in practical terms, for the average person, what does that mean?
It means SMT should be a standard, first-line, non-drug option that your doctor recommends. And that acceptance improves the likelihood of things like insurance coverage and medical referrals.
Okay, let's shift to the other major spinal focus, neck pain.
Similar story, but maybe even stronger. Neck pain recommendations, there were 14 of them, were just as unanimous.
So we're talking
100%. 100% of the guideline statements favored SMT, and that covers all the categories, acute, subacute, and chronic neck pain.
That convergence. Strong guidelines for LBP and universal endorsement for neck pain. It really reinforces that identity of the profession as central to conservative spine care.
Absolutely. But the rigorous science from that third phase didn't just stop at validating spine care. It let researchers push confidently into new areas.
Like headaches.
Exactly. The expansion is significant. And it's the definition of an evidence-based field growing its scope. For instance, between 2019 and 2022, recent CPGs explicitly favored SMT for both cervicogenic headaches and tension-type headaches.
Which is noteworthy because some older recommendations actually advised against SMT for those conditions or just didn't mention them. What drove that change?
It connects right back to the spine. Cervicogenic headaches are literally headaches that originate from a problem in the neck.
Right.
And tension-type headaches are often made worse by neck stiffness. The clinical reality is that about 90% of patients with these headaches also have neck pain.
So as the evidence for neck pain treatment grew, the guidelines for related conditions just followed suit.
Precisely. You prove you can treat the root musculoskeletal issue, and it often resolves the secondary symptom.
Beyond headaches, are there other conditions or maybe specific groups of people where we're seeing growing support?
Yeah, a few. We're seeing increased CPG support for managing pregnancy-related or postpartum LBP. There was a key recommendation on that in 2022.
And what about outside the spine?
We're seeing support for peripheral joints now, too, specifically shoulder pain, which was supported in 2021 guidelines. It clearly shows the evidence is pushing the application of SMT beyond just the spinal column.
Okay, now we have to revisit that major historical concern, the adverse events, specifically the stroke and vertebral artery issue that you mentioned from phase 2. What does the modern data say about the risk?
This is one of the most important takeaways, especially given all the fear around those old case reports. The review confirms that literature focusing on case reports of adverse events has gone down a lot.
And the big studies?
The big modern studies show no definitive causal link between SMT and serious vascular events, like a cervical arterial dissection.
And for the listener, a cervical arterial dissection is just a small tear in an artery in the neck. So if there's no causal link, how rare are these serious events?
As the risk is quantified as rare, I mean really rare. The rates are comparable to or even lower than other common conservative treatments.
Do we have numbers?
The estimates vary a bit based on how they're calculated, but they range from around 1 per 2 million manipulations on the low end to 13 per 10,000 patients on the high end.
So either way, it's an incredibly low risk.
Incredibly low. And that low-risk profile is now being factored into the guideline recommendations that strongly favor using SMT. The whole risk-benefit analysis is strongly in its favor, especially for early use.
That's a crucial data point. Now let's look at the value proposition, which is so critical in healthcare today. What do we know about chiropractic care as part of value-based care?
The large observational studies on this are really interesting. They show that patients who get chiropractic care tend to use other health resources more efficiently.
Meaning, if they get SMT early, it's associated with positive downstream effects.
Exactly. We see things like reduced downstream imaging and a lower likelihood of surgery.
What about medication use?
That's a big one. Reduced opioid and other medication use. Specific studies cited in the review showed an association between getting chiropractic SMT and being less likely to then get a prescription for, say, gabapentin or tramadol for radicular low back pain.
And they adhere better to the guidelines overall.
Yes, patients getting chiropractic care showed higher overall adherence to the CPGs than those who didn't.
That's a huge finding. I mean, in a world fighting the opioid crisis, SMT offers an evidence-backed, non-drug pathway right at the beginning of care.
It aligns perfectly with conservative care goals.
But for credibility, the review authors were also very clear about evidence gaps. What are the key limitations we need to know?
And that transparency is vital. They were clear that SMT was specifically not recommended, or there was just insufficient evidence for several conditions.
Such as?
Things like degenerative lumbar spinal stenosis, degenerative lumbar spondylolisthesis, and developmental concerns in children.
So for those conditions, the guidelines currently say SMT is not the right choice based on the evidence we have.
Correct. And some patient populations are just understudied. Pediatric and older adult populations, especially those with lots of other health issues, are generally underrepresented in these CPGs.
Though the authors did mention new literature is starting to emerge there.
They did, yeah, especially for conditions like lumbar stenosis in older patients.
What about conditions that chiropractors often treat, but where the guidelines haven't really formed a consensus yet?
Well, we noted the absence of CPGs for sacroiliac joint pain, even though there's emerging evidence that it can be effective there. Also, the term migraine was a super high-frequency keyword in the research literature.
So researchers are very interested in it.
Very interested. But the CPGs haven't yet addressed SMT for migraines.
And that's a key distinction, right? The research is happening, but the guidelines often lag a bit behind the cutting edge.
They do. The source mentioned a 2020 meta-analysis that suggested efficacy for migraine, and it even noted a larger randomized controlled trial that's underway right now. The data is coming, but the formal guidance isn't quite there yet.
And that delay, that gap between the emerging research and the formal consensus, that's really what defines the current frontier in this field.
It is. It shows the profession is always pushing to validate its utility for new areas.
So what does this all mean for you, the listener? What's the big strategic takeaway from this 50-year deep dive?
I think the core conclusion is pretty definitive. Over the past 50 years, chiropractic research has undeniably matured. It's moved from legal defenses and safety concerns to generating the high-level trials and reviews needed for guideline support.
So it's now a guideline-supported, evidence-based discipline.
Yes, and it's central to conservative musculoskeletal care. The findings just reinforce the strong clinical utility of SMT for spine-related disorders, especially within those integrated multimodal pathways.
That shift from being seen as alternative to being fully integrated, that's maybe the biggest finding here. Validating its place right alongside exercise and physical therapy in those first-line recommendations.
Now, for a final provocative thought for you to chew on. This review, it focused heavily on low back pain and neck pain as the established areas of support.
Right, the core of the evidence.
But given the new findings, that SMT is now favored for cervicogenic and tension-type headaches. And when you consider the large-scale research happening right now for things like migraine.
Which is a huge debilitating issue for so many people.
Exactly. The research is clearly pushing far beyond the traditional definition of just spine care.
So it suggests the expansion of this kind of evidence-based conservative care into primary headache management. That could be the next major wave of discovery in this field.
It could push these interventions further into general medicine than ever before. The guidelines follow the data.
And the data's moving outward.
That's right.
A fascinating convergence of clinical practice and really rigorous research. Thank you for guiding us through this crucial evolution of evidence.
This deep dive makes one thing clear. Chiropractic care and spinal manipulative therapy are no longer operating on the margins of healthcare. The evidence shows a profession that has matured, one that is now firmly embedded within guideline-supported, conservative musculoskeletal care, particularly for low back pain, neck pain, and related conditions. As healthcare systems face rising costs, workforce shortages, and increasing pressure to reduce unnecessary imaging, medications, and surgery, evidence-based conservative care is no longer optional. It is essential. If you found this episode valuable, please take a moment to like, follow, and rate the podcast. It helps ensure this evidence reaches more clinicians, policymakers, and healthcare leaders. For Pennsylvania Chiropractic Association members, a companion infographic is available to share with staff, patients, legislators, and regulatory bodies. Science-backed information like this is reshaping how conservative care first approaches are understood and applied. Until next time, stay informed, stay connected, and stay grounded in the evidence.